And so at this time, we welcome to the stage no other than Dr. Stephanie Thompson. Let us welcome her.
Okay, thank you very much, Reverend Stacy. It is a pleasure and honor to be here with you guys this morning, speaking to you about Fertility 101. And I think this is truly the meat of a tour like this is education and just learning all of the things that we never learned. We spend a lot of time focusing on how to prevent pregnancy as we grow up, and not enough time talking about how to get pregnant and the barriers that there may be. So I'm Dr. Stephanie Marshall Thompson. I practice in New Jersey with IRMS at St. Barnabas and now CCRM Fertility. We're part of their network. And next slide, please. So this is just a cute, next slide. All right, so this is just a kind of a cute illustration that one of my partners loves to draw, the sperm and the egg. Again, that's just never really learning how it all happens, the cute little uterus to make the baby. Next slide. So the basics of fertility is really the menstrual cycle, right? And when we grow up and we're in elementary school, middle school, we kind of get some basics, but it still remains one of the greatest mysteries. And I think understanding and learning how to track your menstrual cycle and listening to your body is the most important thing that you can do from a young age and that you can teach young kids to do. Next slide. So what happens in a normal menstrual cycle? So first of all, we're born with all the eggs that we're ever going to have as women. And I think this is one of the facts that we are always remiss that we don't teach. So over time, we lose both the quantity and quality of those eggs. The most amount of eggs that we ever have is when we're in our mother's uterus. And then after we're born, that number drops off significantly from about 2 million to when we go through puberty, close to 200,000. And then over time, we just continue to lose eggs. So every menstrual cycle, we're actually losing our eggs. So at the beginning of every menstrual cycle, what happens is we have a little crop of eggs that are immature and they're ready to have the potential to make a baby. Well, our brain uses a hormone called follicle stimulating hormone, and that name may be familiar to a lot of you who are considering or have undergone fertility treatment because we use it very frequently in fertility treatment. That hormone in our brain talks to our ovaries and says, hey, pick an egg and get that egg ready to grow and mature. So as that hormone, follicle stimulating hormone, is growing the egg, that egg starts to get bigger and bigger, and we can eventually see it on an ultrasound and produces estrogen. That triggers us to ovulate, and then that's our opportunity to get pregnant. So we really have 24 hours that the egg is living for the opportunity to get pregnant. So that's why timing is so critical. So you either ovulate that egg and the sperm meets the egg and we get pregnant, or you end up with your next menstrual cycle. So women who have a menstrual cycle that's longer than the norm, longer than 35 days, are going to have less opportunities to get pregnant every year as opposed to someone who has a more normal length cycle. So the average menstrual cycle is about 21 to 35 days. So there is quite a wide range. But the most important thing for you to know is what is your body doing? And know that it's not normal to not have a menstrual cycle. And it's not normal to have one every 6 months. We may be happy and say, hey, that's good, we're not menstruating, but it's actually not good for us. Next slide, please. So what happens with normal fertilization? The sperm goes into our cervix and then passes the uterus and then goes into the fallopian tube. And that's where it meets the egg that's released from the ovary. So having normal anatomy is actually really important, especially for our fallopian tubes, because if the fallopian tubes are blocked or damaged, it can really impact normal fertilization. So the embryo is made in the fallopian tube. Next slide, please. And then it's going to have to travel to the uterus to implant. Next slide. Okay, so the embryo is made in the fallopian tube and then has to travel to the uterus to implant, but it actually grows for a few days in the fallopian tube, which is what this slide is showing. It goes through stages of growth and then it matures and then continues to grow and implants, in our uterus. So that's why the uterus is also important. That's why we talk about sometimes there are issues with fibroids, polyps, as you heard about in the video, and those things can prevent implantation. Next slide. So the amount of infertility is rising. The birth rate in the United States has become lower, over the past 10 years. People are having babies much later. That's a large part of the reason that our fertility is dipping. And then there are other factors, such as male factor. Next slide. So how is infertility defined? One of your pre-questions. Under the age of 35, infertility is defined as 12 months of unprotected intercourse. And over the age of 35, it's 6 months. And that's because that's when we really start to see a decline in our fertility rates. So it's advised that you speak with your doctor if you are in one of those categories and even a little bit before. And I think that women over 40 really should encourage a meeting with their doctor if you've been trying for 3 to 4 months with no success. So when it comes to fertility treatment, which we're able to provide really high rates of success these days. And I think that's a message that is important as we think about hope. There are many ways to build a family. Our science is excellent, and we encourage you to reach out sooner rather than later. The biggest challenge for success with fertility is getting people to our doors. So low drop-in and then high dropout. It can be a challenging and frustrating process, and that's why support groups, such as Fertility for Color Girls, are so important in this journey. Another challenge is the information gap, as well as Dr. Google. So some of just the basics of the menstrual cycle and trying to conceive, we don't know that, and that's okay, but we've never been taught that information. So just getting the basics of learning about our bodies is crucial. Next slide, please. So infertility is now 1 in 5 couples. It was 1 in 7 a few years ago. We're now 1 in 5. We also, need to mention our LGBTQ communities and the many ways of family building, and I'll go into that a little bit later. And then we also have men and women who don't have a partner and want to have a child. There's a lot of opportunity for them as well. 1 in 4 really refers to the amount of female physicians and professionals. So, there is a relationship as well, waiting longer, completing your degree, the higher rates of infertility. Causes of infertility, next slide. So about 50% female, which includes ovulatory disorders, such as not ovulating and not releasing an egg monthly, as well as tubal factor. Remember, I mentioned that the fallopian tubes are crucial for the sperm and the egg to meet properly. Male factor is about 35%. Okay, and I think we have a real challenge sometimes with our guys in understanding that they are a huge part, and a lot of women are taking it all upon themselves that they're the reasons that a couple can't get pregnant, but that's not true. It's a huge factor is male factor in fertility, and often also in combination with female factor. There's about 10% that we never find a reason. Okay, and I think it's probably even a little bit higher than that of why couples don't get pregnant. And it's also frustrating. You go through a workup and you don't find anything, but it's actually okay. Those couples do well, with fertility treatment too. Next slide. So the initial evaluation, we're not scary as fertility doctors. We're doing a lot of telemedicine now, and so I think patients have the opportunity to just have a consult and talk within, the confines of your home or office, and it's a little bit less intimidating. We start off just with a general history. That history, we want to know about your menstrual cycle. We want to know about any issues that you had, STDs, et cetera. And a medical history is extremely important for both men and women. The medications you're on, some of them do impact your fertility. So a really thorough history is important for us to take the next step in helping you to get pregnant. A physical exam is also crucial. We do ultrasounds where we take a look at the ovaries and physically can look at your egg count and make sure it's appropriate for your age. And then we also will do what's called ovarian reserve testing. So as I mentioned, women are born with all of our eggs, and we will all lose them. Being in the best shape possible is wonderful, but the reality is that your overall health is not going to particularly change your egg count. There are some studies, obviously, if you are overweight and obese, that does affect your egg count too. However, the reality is that we all kind of go through this at probably a similar rate, but there is a spectrum. So like someone may go through menopause at 50 and somebody else at 60. There are women who will lose their reserve earlier in their 30s rather than later on, and that can contribute to difficulty. We look at your anatomy, so the fallopian tubes again, and then an evaluation of the male partner. Next slide. Okay, so I mentioned to evaluate ovulation, things that we use in your history, basal body temperature charting. Some women will do that, where you measure your body temperature in the morning to see when you are ovulating, or using ovulation predictor kits at home can be helpful. We check your hormone levels on the 3rd day of your menstrual cycle, because if you remember, at the beginning of the menstrual cycle, all of your hormones should be nice and low and preparing to grow an egg. So we make sure that there's no reason that your brain has to work really hard to get an egg to grow. And then we do an evaluation of the uterus and fallopian tubes with a hysterosalpingogram. And if any of you are going through this testing, it's probably described as a little painful, but it's an X-ray where they put dye through the inside of your uterus. Next slide, please. When you come back to that. So the HSG, go one slide before, please. That's okay. So I just had a picture of an X-ray where what happens is we'll put dye on the inside of the uterus through the vagina and watch that dye flow out through the fallopian tubes to make sure that they're open. Also gives us a snapshot of the uterus to look for big fibroids or polyps or congenital issues you may have been born with. So I mentioned ovarian reserve testing. So we look at 3 things when we're looking at your egg count. We're really looking to make sure it's age appropriate. Just because you have a low egg count or elevated follicle stimulating hormone and estrogen we check on the 3rd day of your cycle doesn't mean you can't make a baby. So I think it's very, very important, and we need to be aware of some of these kind of home tests that don't give us all the information. It's very important that your test results are properly interpreted, because I've had people come and say, look, I did a test at home and it took me 6 months to get to you because I was just so freaked out and scared and I didn't want to hear what you had to say. And I look at it and I'm like, we can make a baby. So I think we have to be cautious of the Dr. Googles and everything that's out there and make sure that we're interpreting these things properly. So there's something called anti-Müllerian hormone, which is the hormone made by your resting eggs. And again, that's a reflection of your egg count. And then on the ultrasound, we look at your ovaries physically and count the number of resting eggs that could grow that you would ovulate, to make a baby. So this graph just illustrates, the number of eggs and the decline over time. And you see 35 to 37 is when it really starts to decline, and 37 and onwards is an extremely sharp decline. And that's why 35 is picked as, the age at which is 6 months of trying rather than a year for infertility. Next slide. So this slide just talks about the percentage of pregnancy rates per age. Age is the most important factor when it comes to fertility. We can do a lot, but that's one of the things that we cannot turn back the clock. So age is extremely important. And I think it's important for everyone to understand it's never like 50% chance that you get pregnant per month. The highest it is really 25 to 30% when you're in your late teens, early 20s. Then that drops down by the time you get to 35 to about 15%. At 40, about 5%, and then when you get to 45, less than 1%. And this is chances of pregnancy, what we call fecundity, per menstrual cycle that you have. So again, if you have a menstrual cycle every 3 months, you're just not getting the same attempts at pregnancy otherwise. So extremely important to recognize this. And I think this is information that we have to get out again from, when we're in our teens and part of our health education, because we have to start thinking about these things. Next slide. So the male factor, we look at a semen analysis. So we look at the count of sperm and the amount of sperm that's available to fertilize an egg. The morphology, which is the percentage of normally shaped sperm. Sperm have a head, tail, and midpiece. Those all need to be shaped properly to fertilize an egg. The motility, how they can actually swim like this picture. I don't know if you all remember probably the old Look Who's Talking picture like this from the movie. And the sperm are fighting, and it literally takes one sperm to fertilize an egg. And then the volume as well. Next slide. Just a wild slide. Okay, next slide. So sperm counts have gone down over time, probably environmental and occupational factors. Male factor infertility does continue to increase. Next slide. I mean, this just details, the hope we have. The percentage of live births, is actually quite good when we do fertility treatment, 3 to 4 times your natural fertility rate. But again, it does decrease over time with age. Next slide. And just to talk a little bit about miscarriage. The most common reason for miscarriage is chromosome abnormalities of an embryo or the baby, and the embryo not having all of its DNA. And so what happens is, because our eggs are the same age that we are, when the egg is fertilized and starts to grow and divide, it starts to make errors. And with those errors, the body will communicate with the embryo and know that it's not normal, not going to make a healthy baby. It won't even implant. It could implant, and then you have an early miscarriage. Most miscarriages are in the first trimester. But we must know that it's nothing that we did or could do. And I think about 80% of women have had a miscarriage. And talking about loss, I think also helps us to kind of move forward, because I have many, many patients who will say, they have a difficult time after a loss, and now they're waiting 6 months, they're waiting a year to come back to fertility treatment. And I think if we had a greater conversation and realize how common miscarriages and losses are, then we'd be able to support each other better and be able to go through with treatment going forward. Like Debrat talked about, she didn't feel like trying again, but it's a journey, and sometimes we have to just keep trying. Next slide. So Black women and infertility, are we different? Next slide. Yes and no. Is our basic physiology different? Absolutely not. Are egg counts higher? Are things different for us at 35? They're not. So really, there is no difference in physiology, and the medical system has often treated us like there is. There's this thought that Black women aren't infertile, and we're not going to have difficulty getting pregnant. That's not true. There are lower pregnancy rates from fertility treatment. I'll go into that a little bit more, but we take a much longer time to get to fertility treatment, and a lot of it is lack of education and the stigmas. We have higher rates of obesity in our community. That's true. We have higher rates of tubal disease and higher rates of fibroids. Just because you have fibroids doesn't mean that you're going to have difficulty getting pregnant or that you can't get pregnant. Okay, 80% of women have fibroids. The location of fibroids are very important. So again, making sure that you have a proper evaluation. And I encourage you, if you're considering a procedure to address fibroids and something maybe doesn't sound right to you, to get a second opinion. There are procedures out there that can render you infertile from taking care of fibroids, or you have a much lower chance of getting pregnant. So it's very, very important to make sure that when your fibroids are being addressed, that you have the right treatment for them. So it's never bad to get another opinion, especially if you just feel like things weren't properly explained, or they say, hey, there may be a decrease in you getting pregnant. I'm not sure how significant it is. make sure that you understand absolutely. Next slide. So inequities in our healthcare system, again, the belief that Black women are not infertile. There's a poor recognition of medical conditions that are not traditionally taught to us about Black women. For example, in medical school, you're taught that white women have endometriosis and Black women have fibroids. So Black women with pelvic pain traditionally are not put in the category of having endometriosis. And this has been one of the things I think that has been the most heart-wrenching for me, seeing patients, Black women with endometriosis in their late 30s who was never recognized, they probably had it their whole lives, they were never put on any therapy to help prevent the growth of endometriosis. And if you don't know what endometriosis is, it's when the cells from that inside of the uterus, like when you're supposed to shed menstrual blood every month, go actually into your fallopian tubes, into your abdomen, and can implant there and can cause a lot of pain. It can cause blocked fallopian tubes, cysts on your ovaries. It's just a general inflammation in your reproductive system. Access to care, has been a huge thing. Now, this is getting better. I encourage everyone to check your benefits. We know fertility treatment is expensive. The technology is expensive, but we're getting a lot better. Big companies like Amazon, Google, are really covering fertility treatment much more so than they were before. New York is now a mandated state for fertility treatment. I practice in New Jersey, where we have been for years. So now we have 14 mandated states for fertility treatment, meaning that if you work for a company of a certain size, you should have insurance coverage. We need to have 50 states be mandated for fertility coverage, and we'll get there. So there's a mistrust in the healthcare system. I'm sure you all are familiar with the Tuskegee experiment, and forced sterilization in the South was very real. So forced, tubal ligations, removal of hysterectomies, when women had not completed their childbearing. These are all very, very real things that, of course, we have mistrust in the healthcare system. Next slide. Obstacles to better outcomes, social stigmas for ourselves. We are not sharing. We are taking a long time to get to fertility treatment, I think because we feel that we shouldn't be infertile, right? It's truly should be a natural human right for us to be able to get help and to have a child. And there's help out there. Lack of access, I talked about, socioeconomic and geographical. You're very lucky today, having a few Black board-certified REIs in the room. There's probably maybe 60 of us in the country. So, if you live in the middle of nowhere, Iowa, and you are not comfortable and you want to find a Black fertility specialist, it's difficult. There's lack of cultural awareness in our own centers, just like there is in healthcare. I know our group is doing a lot to address that. We want to make sure that our staff understand the experiences that Black women have that are different, okay, because we have to acknowledge that. There's older age once deciding to seek treatment, and then obviously lack of support systems and networks that groups like Fertility for Color Girls are addressing. Next slide. How am I doing on time? I'll go through quickly. So I just want to address two other things quickly. Why are frozen eggs so hot? Freezing your eggs, you saw that in the intro video. Fertility preservation is very important now. Next slide. So we used to just do egg freezing for cancer patients, but in 2012, ASRM, who is our society sponsoring today, says that it's no longer considered experimental, and we can do fertility preservation to help you get ready to have a child in the future. And for women who do suffer from cancer, part of the counseling should be that you have fertility preservation available to you, or egg freezing. Next slide. So this is just one of our slides, to Emma, from Emma. So an age 30-year-old Emma decided she wanted to freeze her eggs, which, essentially the concept is just getting as many eggs possible from you at this age with the intention of using them for the future, because the pregnancy rates do decline, not just naturally, but also with fertility treatment. Next slide. So is a luxury or a necessity? We talked a little about the expense. Again, check benefits is becoming part of a benefit package. Next slide. Actually, we can go to the next one after this. Okay, so more women are freezing their eggs. A lot of it has to do with delayed childbearing. Again, more insurance coverage, the fact that it works really well. I encourage you to consider egg freezing if you're not ready to have a baby. The outcomes under age 35 are excellent, and we even have good outcomes, up until 40-ish. So everyone is different. Everybody deserves the opportunity to have the conversation, with your physician. Next slide. And we'll go to the next one. So just why is egg freezing more successful now? From a lab standpoint, we've changed our techniques. We now flash freeze eggs in liquid nitrogen, similar to what we do with embryos, so they can be used for the future. Next slide. So we do think that fertility preservation is a way to help with low birth rates in the United States, and that's why everything should be covered. The government should cover it. Next slide. So just be proactive about your reproductive health. Get informed. It's okay to get a second opinion. You don't want to regret, again, as she said in the video, the opportunities that we may have. For things like egg freezing, it takes 2 weeks, and it is definitely a short snapshot of your life that can be, very important in the future. It is not a guarantee at all, but it's important to see what your chances may be and what that looks like for you. And next slide. I'd be remiss if I didn't mention LGBTQ family building as well. A lot of options. Next slide. And I thought this was pretty cool. There are 31 ways to make a baby. Okay, so making a baby isn't just a heterosexual man and woman. We have a lot of single females, single males who want to make a baby and can make a baby. We have egg donation we can use. We have two couples together, and we have co-maternity, which is where one woman may make the eggs and her partner will carry. So we have a lot of different options, and adoption as well is an option. All right, next slide. It's a cute illustration of all the ways to make a baby. Next slide. And this is my group, CCRM New Jersey. So we are here and available for any questions. And thank you for your time and attention. And I think I have a quick Q&A. Okay. Hi.
I did put off my fertility. I had a baby when I was 16, put it off for a long time, went through med school and everything. But I wanted to know, are there grants? I was told there are grants for couples who, or persons who, are on this fertility journey.
Yeah, absolutely. First, thank you so much for sharing those hospitals. And yes, there are grants, and I feel like we don't advertise the availability as much. I know Reverend Stacy's been really trying, and I'll let you speak about your grant. But there's plenty of foundations out there that do provide grants. And it's our, go ahead, yeah. Oh, yes. So today we have a $10,000 grant for fertility treatment that you can enter the raffle for. So there's definitely programs. Yeah.
Hi,
I was wondering if there are any working theories on the increase in male fertility.
Yeah, I think probably environmental and the use of things like PFAs and BPA, et cetera, over time that probably have an impact on the male factor. One thing, sperm are very temperature sensitive. So it kind of is true. We are always telling guys who are cyclists, the Peloton and all that, to scale back on that a little bit, like no hot tubs, saunas, et cetera, true. But, probably just all of the environment and pollution and, everything else that's going on now. And also, the antihypertensives, anti-cholesterol medications, because we are in not the best health, especially as a Black community, do impact sperm quality and quantity.
Yes, hello. Long-term birth control, like, 5-10 years, does that affect getting pregnant when you finally
Oh, thank you so much for that question. That was my thesis project as a fellow, actually. I'm sorry, as a resident. But no is the answer. I mean, up to 10, 15, 20 years, it should not impact your chances of getting pregnant. Now, when you stop a birth control pill, it can take a little while for your cycle to come back. So, do prepare anywhere from getting a period back right away to up to 6 months, but it should not impact your overall fertility rate. Morning.
I didn't expect to be on the mic. I have a quick question. I currently go through IVF treatment, and my husband and I have been trying for, 2 years with 3 failed IVF treatment. He actually tries to coax me in between the cycles. Can you explain the effect of pausing the cycles, effect of the hormones or stopping the hormone treatment? How would it affect your body in between cycles? Say, for instance, if we chose to just take a pause for 6 months and then go back, or maybe a year and then go back.
It's a great question. I would encourage you to not pause. And I know it's hard. I do. I know it's hard. But I would encourage you to not pause. Okay, there's no adverse effects really of going in back-to-back cycles, but there is adverse effects between 6 months and a year in your chances. I'm not going to ask you how old you are, but really, frankly speaking,
Is it because the body has to recalibrate the hormone levels?
no, you mean in going back to back. So once you do an IVF cycle, and just to give everybody a synopsis, what you're taking in IVF is follicle-stimulating hormone grows the eggs, and then we remove them from you surgically, grow an embryo, and implant it. Once you finish an IVF cycle, your hormones go back to normal by the time you get to your next menstrual cycle. For some people, it may take another cycle for them to get rid of sort of the bloating and the side effects of your having elevated estrogens and being sometimes emotionally like a bad PMS, et cetera. But, the reality is that you don't need 6 months for hormones to quote unquote rebalance. They should get back to normal, and success rates are going to be higher the younger you are. But you bring up a great point, because I know that it can take a lot to recover, physically and mentally between cycles, but I do encourage you to keep going. And I think support groups and, having a network of people help you to keep going, right? Now, 2-3 months, yes, if you really just need a little breather, but I encourage people not to get to the year point in taking a break. Yes.
Good morning. Thank you for everything. My question is sort of general. Can you comment a little bit on secondary infertility, or is it just all the factors that you mentioned that contribute to it? Or
good question. It's mostly probably age, to be honest. But yeah, we do see a lot of secondary infertility. I think age and what we call ovulatory dysfunction. Again, I've been having longer cycles, not ovulating regularly. All the things that I mentioned too. Increase in medical problems as we get older. All of it really, but it's probably age. Any other questions? Okay. Thank you all.
Hi, everyone. My name is Maureen Siebert. I am a PhD prepared nurse researcher. Hi, Tia. I was looking for you earlier. I am just so blessed and excited to be here. And when I saw the event flyer, I immediately called Dr. Reverend Stacey Dunn. I was like, can I be a part of this? And so this session that she wanted me to talk about is just the importance of sharing your story. Sharing your story to one, encourage yourself and to encourage others. So I actually don't necessarily have a full infertility story. However, when I was 24 years old, I mentioned I'm a nurse. I was 24 years old working in the emergency department at Bridgeport Hospital in Connecticut. And one day I woke up and I had really bad right-sided pain. And I was like, great, I have an appendicitis. After several scans, CAT scan, MRI, everybody's looking confused. There's this huge tumor on my right ovary. And I went into surgery, and I woke up from surgery. I remember just super groggy, and the OB/GYN who did the surgery goes, great, we were able to save your ovaries. There was just a little bit of a ovarian torsion, so your ovaries were twisted, and we could just take out the tumor, and it looked fine. And I remember my first question was, wait, there was a chance I could lose my ovaries? I had no idea. That was never discussed in, the pre-op checklist. And so from that moment, because of the size of the ovary, I had to be off of work for about 6 weeks or so. And I'm just thinking, I'm like, I could have lost my ovary or something else could have happened. What if I woke up and had a full hysterectomy, right? And I would have never known the risks that I actually signed up for. And so at that moment, I was trying to figure out what I wanted to do when I grow up. And I knew I wanted to go to grad school. And me, I'm a spiritual person. I just started praying. And immediately I heard this name named Hannah. And for whatever reason, I went into my Bible and I found this story of this woman named Hannah praying for her child. And then all of a sudden I heard the story, the name Elizabeth. And then I find, whoa, Jesus' cousin was the result of delayed fertility. And then reading stories where I just finally find this unnamed woman who is the mother of Samson or Gideon. And all these stories, and this is how I got into it. And so I had the opportunity to go to graduate school and got really great funding to go to Winston-Salem State University for my master's in nursing. And right before I left, one of the emergency department doctors goes, oh, Maureen, I hear you're going to grad school. What are you going to study? I was like, I'm going to study Black women with infertility and what makes all this stigma and decision-making and delays and all that stuff. And he goes, oh, that should be a very short dissertation. Because it doesn't happen. So I used that as fuel, came down to Winston-Salem State. Then I bridged over to Duke University, and I really felt like in those moments, actually, when I was at Winston-Salem State, I just had the unction to ask my program, could you pay for me to go to this conference? It's in Baltimore. That year, the American Society of Reproductive Medicine Conference was happening. And then I meet Dr. Camille Hammond, who has the Cade Foundation. She goes, come here. And I go to this event with her, and this whole world opened up. And then women just started coming to me and telling me stories. And then I finally go to Duke for my PhD, and I interview women through Shady Grove Infertility. And these women told me of these recurrent miscarriages. These women told me of these times where them and their partners were the only ones who knew about what was going on. And they would say, Maureen, you're the first person I ever opened up to. When I got their names, it was from a random sample of about 3,000 Black women that fit my criteria. And they would say, I'm probably the only one that's experiencing this, but, and then they would just tell me this super generic thing that I've heard several times before, and in my head, I was just like, why don't you share your story? You would get more support. Why wouldn't you share your story? You could help other people. And so from there, I learned a lot of things about the primary care experience and GYNs, maybe not referring to reproductive endocrinology like Dr. Thompson or Dr. Jackson Bay and Dr. Douglas. Like, these are people who are open to treating you all, but they just don't have access to you. And so now I am part-time faculty at Yale School of Nursing. I'm part-time because life lifed. And I'm hoping to get back into full-time research. But if I can encourage you all today is to tell your stories, ask your questions, encourage one another, and support people where they're at. Okay? Thank you. I love that dress. Great to see you too.
Okay, good morning, everyone. It feels so formal with the mic. But I am Dr. Tia Jackson Bay. I'm a reproductive endocrinologist and infertility specialist here in Brooklyn. I work for RMA of New York. And I really just wanted to give a little historical context to the issue of infertility in Black women, because as you've heard this morning, it is amongst us, right? This many people wouldn't be sitting in a room if it was not. But there is still such a prevailing misconception that this does not happen to us. And therefore, I wanted to kind of tease out why that could be. Also shed some light on other people around us who've gone through this and try to just lend some support. So we'll go to the next slide. So next slide. I think it's, I'm really encouraged by the amount of celebrities that are actually being honest with their conception stories. And even if we don't know all of the fine details, I'm just really proud that people are feeling comfortable enough to share it, because you go through so much. It can be very isolating, so stigmatizing, but to share your story can give so much more encouragement and education to the public. So this is Tamarind Hall. She's a famous journalist and TV host who was very vocal about her fertility journey and having a baby, I believe at age 47, with the help of in vitro fertilization, IVF. Next. And we may know here Gabrielle Union, her husband Dwayne Wade. I think for a long time people assumed that maybe they didn't want children together. What we didn't know was there was a backstory where she was suffering through recurrent pregnancy loss, which we'll talk a little bit more about, and having a lot of miscarriages. So Dwayne had children, prior to their union, and people maybe thought they didn't want children without realizing that there was this other part of the story. And so they finally were able to have their daughter through the use of a gestational carrier. Next. And Tia Mowry, another kind of popular face from TV, an actress, had a long battle with endometriosis, which was something that, again, I think is sorely underdiagnosed in Black women, again, because of medical training, helps, unfortunately, perpetuates that this is something that Black women don't experience. And that's unfortunate because it can have really significant impact on your reproductive health and outcomes. Next. Naomi Campbell actually became a mom recently and is not given full disclosure of the details, but I think, again, it's just important that if you want to parent, if you want to mother, there are ways to do that. It may not always look like what you thought it would. It might not make sense to other people, but there are still opportunities for you. Next. And same with Janet Jackson. This is probably the one that people push in my face mostly when they come into the office demanding their baby. But I think it's, just again, important to know that regardless of, what the world thinks or what opportunities you may have in front of you, there can be ways to parent. We don't know the exact circumstance of some of the celebrities. I'm, of course, thinking that there's IVF involved, but something that is not as much discussed is the use of donor eggs. And, for women in their 40s and 50s who are conceiving, a lot of times it is going to include eggs from someone else, embryos created from someone else, or maybe eggs that they froze and saved from years prior. Next. And then similarly with Tyra Banks, she was another person who was able to become a parent with the help of a gestational carrier. So I love the biblical references because there's a lot of ties there with someone else carrying your baby. Nowadays, gestational carriers do not have a relationship to the child they carry. They are literally a helper. It is not their child, it's your child, and there's a whole kind of thing that goes into that. But I think it's important to remember that that is another way to help build your family. Next. And, Angela Bassett and Courtney B. Vance, they also had their children, I think they're twins, through gestational carrier. Next. And another thing I think is important, and I think the next two are here, Shonda Rhimes became a parent as a single woman, and she adopted. She has 3 daughters, and this was something that was really important to her in terms of wanting to mother, wanting to do it on her own terms, and realizing that, yes, adoption is a way to build your family as well. Next. Yes, and this is Viola Davis and her husband with their daughter, Genesis, who was also adopted. Yes. Next. I think we heard a lot about Keke Palmer recently, but one that she didn't disclose until maybe she was going through this journey is she was someone who suffered from an endocrine condition called polycystic ovarian syndrome, which is very common amongst reproductive age women, and as Dr. Thompson mentioned, it can affect your periods. Some of the women don't have frequent periods, and it can be harder to become pregnant as a result. So this was her kind of triumph over PCOS. Next. And of course, we've heard a lot about the Brat and Judy. I think they're just getting a lot of shine because it's a very interesting story, and it's, you know, we're very excited for them as a couple. Next. And I don't know if anyone read Becoming, the memoir of Michelle Obama, our former First Lady, but our first daughters were conceived with IVF. So this is, again, it's around us, it's in our communities, it's being utilized, and I think we need to understand that. Next. Okay, so I think if nothing else, I want you to just remember a few different things. Infertility is a disease. It is a malfunction of the way that the body should work. It is not a social problem, you know. It is not a punishment for something you did or didn't do before. It's not a rich person's problem or a poor person's problem or a white problem or a black problem. It's a disease like asthma or diabetes or high blood pressure. When you have these issues, you go to the doctor, you manage it, you correct it, you have surgery, you take medication. So we have to kind of get into the view or get into the mindset of viewing it in that way. Again, infertility, as I mentioned, does not discriminate. You know, we are human beings, you know, and have the same opportunity to experience this as anyone else. There may be things that create an even higher risk in our population, and some of that is education. Knowing how a history of sexually transmitted infections can affect you in the future, knowing how fibroids can affect you, or an ectopic pregnancy, things like that. So again, this is not something that discriminates. And then the last thing is infertility is not a dead end. I think sometimes people are very afraid to come to see us because they feel like once it's said, or once you say something like you need IVF, then automatically it's not gonna work. Infertility, you know, getting to that point where we have the diagnosis is the beginning from our standpoint, because now we can figure out what needs to be done to get you to the end point that you want, which is a baby coming home with you. Next. So another thing that I think is important to remember is race is a social construct, right? There's no biologic difference between us and people who don't look like us. This was a system that was in place in order to maintain hierarchy amongst human beings from centuries ago. Now we have continued it and continue to study race as a factor in a lot of different things, but this is really a proxy for so many other things: socioeconomic status, lifestyle, geography, language spoken, but there's no biologic difference, okay? Super important to remember. Next. And I always like to put this one in there. Next. So I think that there's been a lot of conversation around Black maternal mortality, particularly in New York City, where we have a particular burden, unfortunately, and realizing that, Black mothers at more risk for death in the perinatal period. That means either during pregnancy or in that year after. But one thing that I have, just felt curious about is, to me, infertility care is on this same spectrum. It's still women's health. It's still in the same, we're fighting for women's rights in so many different ways, and, the autonomy over our bodies, as well as infertility care and coverage. And so I just want to make sure that we're included in this conversation. Next. And so this is just a little bit about some of the pregnancy-related deaths. I'm going to skip over it. Next. And talked a little bit about risk factors for pregnancy loss. As we discussed, miscarriage is something that happens commonly. It is not commonly discussed. So many people, when you go through it, you would think that this is something, terrible that's happened to you without realizing how many other women in your family, in your church, in your sorority, in your college have also had this same outcome. Now, there are some things that can be that can increase your risk for having pregnancy loss, and you see on there, Black race is one of them. I think, again, you have to remember that it's not race that increases your risk. There are other factors that are associated and are common amongst people with Black race. Next. But one thing that, as we mentioned, despite having so much knowledge and awareness, there still is this inequality in terms of access to infertility care and to understanding the treatments and diagnoses. So, as compared to white women, Black women are half as likely to present for fertility care. They also have a longer duration of infertility at the time we meet. So as Dr. Thompson mentioned this morning, typically if you have not achieved pregnancy in a year, then we would say, okay, this is when you need to start investigating. For women who are 35 years or older, we actually want to see you at 6 months. So sometimes when we see Black women in the office, they've been infertile for longer than a year, 2 years, 5 years, before they're ready to seek treatment. Unfortunately, those extra years can kind of cost you success, because the sooner we're able to see you and act and get started, the higher your chances of treatment success. So again, I think it's super important to not just, people in this room, to spread the word and to talk to people and to talk to families and friends, so that if you know that they're struggling, to make sure that they enter care sooner. We do have some lower utilization of the most effective treatments. We know that this can possibly be due to stigma. It can be due to cost. It can be due to access. So, treatments like in vitro fertilization, which is a standard of care in fertility treatment, people hear that and they may get turned off, or they hear it and they see the sticker and they say, well, that's not something for us. And so they leave treatment sooner than we can help them. There's higher rates of treatment discontinuation, as I mentioned, and then sometimes there can be different outcomes even when two people get the same treatment based on race. Next. And so I like to think of these disparities that we talk about is really just the tip of the iceberg. There's more going on here than we can really see from the surface level. Next. And so the Black fertility myth is something that I feel like I talk about pretty frequently, because it's something that is part of my everyday in the office. And it's this idea that somehow Black people do not have infertility. It's not just from, it's kind of started as a stereotype that we also internalized and believed. And it's like, they did it. Because they made you believe something that was not true about you, to the point where now it's affecting your chances of success. And so I'll go to the next slide from here. And so it sounds something like Black women don't have infertility. You may see this in medical schools or in conversations in church, or like people are like, what are you talking about? That's not true. Or just in actions, totally focusing on how hyper fertile Black women are. Their fertility needs to be controlled. You need to be sterilized. In medical training, when I trained as an OBGYN, and before women who just had a baby go home from the hospital, there was this fixation on contraception. She can't leave until you say what the contraception is. She needs Depo, she needs birth control pills. And it was like, she just had a baby and she's gonna relax for a few months. And it was just this fixation that I later realized is coming from this. Next slide. So the Black women being super fertile, next. And we wanna know where it comes from. Well, unfortunately, in this country, it comes from the legacy of slavery. There really is nothing that impacts our community that cannot be tied to this. So we can't tiptoe around it. We can't kind of erase it as hard as they're trying in, Texas and Florida. It happened, it was real. And it affected so much of, what is still happening today. And so I think that's something that we really just can't work around. We have to work through it. Next. And so, understanding that we were brought to this hemisphere, not just this country, but many other countries, as labor. You had to work. That was the purpose of us being here. Next. And so it came to a certain point where, the American people said that actually we're not planning to import humans from Africa forever. We wanted to stop that. So they put a series of laws in place when the country was created to ban the importation of Africans after a certain point. The issue was between when they wrote that and when it actually happened, slavery became hugely economically beneficial. I mean, you can't even imagine. I think it's probably akin to a gold rush or oil rush in the Middle East. Like, this was something that they had no idea how much money it was going to make. And then you said, you're gonna stop it? There's absolutely no way we can do that. But it was already in the books. So you had to create a new labor force. You had to create new humans, right? And so this is how this happened, is that there was, forced sexual violence against Black women. There was coercion between Black women and men in order to create new people to have a workforce that continued. So this is a very different situation than, people who just, chose to have a baby every calendar year. Could you, no, that's not a real thing. This was a service, this was forced, this was constrained, and this is the outcome. Next. And so families were large. And that was just the way it is. And this is a picture of my family, only one side of it, might I mind you. And I love these people, and they're amazing. But, we internalized that. We needed people to, even after, formal slavery was over, you still needed people to work the land. A lot of us, may have been sharecropping in the South or agriculturally based. And so my grandparents came from the South, and so this was what you did, and this is how you lived until, migrating to northern and western cities where you couldn't have, these really large families. And so naturally, families got smaller and smaller. But this is kind of where this idea comes from. It was forced on us. Then it was out of necessity and adaptation. And then now it doesn't fit the narrative, so maybe we waited longer to have children, or you had less children, but it doesn't mean that there was not infertility or the potential for it throughout the whole thing. Next. So this has a really huge impact at the individual level, just having this knowledge of this kind of contradicting message that we're supposed to be hyperfertile, we're supposed to have lots of children, and then when it doesn't happen for you, wow, that can be crushing because it's counter to everything that you were taught growing up. And so it can be really stigmatizing. Having these large families may lead people to think that, okay, we won't have any issues ever, or this is the story I hear the most and I understand it, but the women in my family have children late. My grandmother had children when she was 50, or my grandmother had children when she was in her 40s. Both of my grandmothers had their last children in their 40s, but they had started 20 years earlier. So it's a little bit of a different time. Their exposures were different. They started differently, and it's not the same as now coming in later in life, ready to start your family. As I mentioned, I think, it contributes a lot to the grief that is experienced for Black women. And then as we talk about it less, there's less support because we're just less connected because there's so much shame and stigma associated. The lack of reproductive awareness, I think, is a potential barrier, because just understanding how our bodies work, understanding what are some of the different systems that can either help or enhance your fertility can really, make a difference in who has good outcomes and who does not. And it starts at a young age. And so I really encourage, honest discussions of anatomy with your children, with the young people in your life, high school age, college age. They need to know as they're going along, yes, maybe we don't want you to get pregnant in high school or in college, but when you're ready, this is what it takes. When you're ready, this is what it could look like. These are the people who you need to see and discuss with. And then we know that there's so much mistrust of the medical system, and even as a Black physician, there's still a lot of mistrust of us, and I understand it. But I think that serves as a really big barrier to getting to the goals that you want. Next. And then we can't take for granted that we're not the only people hearing these messages, right? They were created and perpetuated by larger systems, including the healthcare system, government system that allowed forced sterilizations. And so, this permeates lots of different industries, including the medical industry. And so we talked a little bit about doctors not referring someone who meets the criteria for infertility or who says, listen, I want to get pregnant. The doctor's like, just keep trying. That's actually an inappropriate response, but it happens, and I hear the stories a lot when people come in. This very singular focus on contraception, contracept, without what's the next side of it? When you're ready, it looks like this. Have you considered freezing your eggs? What is your timeline? These are the things that should be discussed. Assumptions on reproductive timelines, I think, is another huge issue. When we talk about going into a doctor and maybe they say, oh, she won't have issues, or if she's 40, she's not going to worry about it. And then they can do a procedure that actually works against your reproductive desires. And so again, this is, twofold. It's on the medical system and on the patients themselves to, one, express your desires, but then also not for this to be overlooked. And I think that's so important. And there's still bias about who is worthy of parenthood, right? Who deserves to be a parent? Do you deserve to be a parent if you're on Medicaid? Do you deserve to be a parent if you're a single person, or if you already have children? Or, so there's all of these biases that kind of play into it, as well as who can afford treatment. Maybe they're not being sent because they're like, oh, she won't go because she can't afford it anyway. I've had patients bring a bag of money into the office or say, give me 6 months and I'll be back. You cannot discount people based on what you think they can afford or cover. And so that's an issue. Next slide. So we talk a lot about the natural fertility with the decrease in natural fertility with age. I always like this slide because it shows different populations over centuries, and populations where women just typically have children. There's no contraception. And then when do the babies kind of stop coming? And so naturally, they really stop coming around age 41, 42. Like, they just kind of stop. And that shows us that even at a natural level, there is this very real decline that can, naturally decrease over time, but then significantly in your early 40s. Next. And so there are a few different things that decrease with age. One is ovarian reserve. The actual number of eggs that you have available will absolutely decrease. But semen parameters also are affected with age. And I know, yes, we hear stories of men still having children in their 70s and 80s. It's an exception, it's not the rule, but there are changes in men with age as well. Your pregnancy rate goes down, as well as live birth rate. But then your risk for miscarriage and aneuploidy is a fancy word for having an abnormal number of chromosomes increases. And so these are some of the things that we see with increasing age. Next. So, in terms of your increased risk, there are a few things that we care about or want to highlight as particular risks in Black community. Tubal factor infertility, as Dr. Thompson mentioned, the fallopian tube is really like where the sperm and egg meet, and then where the early embryo has to kind of grow, navigate, and then make it to the uterus in a very certain specific time frame. So if there's any issues with the fallopian tube, this can significantly impact your chances of success. There are, sexually transmitted infections, particularly chlamydia, gonorrhea, or pelvic inflammatory disease that can cause scarring in the fallopian tubes, even if you didn't have any symptoms, but that increases your risk for having tubal factor infertility later in life. Using contraception is also something that can be stigmatized in our community, especially hormonal contraception. And I think that's still an uphill battle. Of course, I would want more options that can be suited and tailored to different people. But contraception can actually be a very significant tool in reducing heavy menstrual bleeding, PCOS management, endometriosis, things like that. It also helps to prevent unintended pregnancy. So if, one thing that we see is women who may have their children young and then through coercion or through circumstance have their tubes tied at a young age. So like less than 30 is a young age. But then later in life, they have a new opportunity. They're in a different stage in life. They have a new partner and they want a new child, and you're not able to because you had your tubes tied young. So, using hormonal or reversible contraceptives could have meant that you had a way to just remove the contraceptive and restore your fertility instead of needing advanced care like IVF or surgery. And then surgical management of ectopic pregnancy. Ectopic pregnancies means that there's a pregnancy that is growing, but it's in the wrong location. Instead of it being in the uterus, it's typically in the fallopian tube or sometimes even outside, like in the ovary. But these pregnancies, unfortunately, cannot continue. There have been studies shown that say that Black women are less frequently offered medical management of ectopic pregnancy, which is an injection typically, and that allows you to preserve your fallopian tube so that you can try again in the future. More likely, they're offered surgical management, which was removal of the entire tube, which can impact your chances in the future. And I have had patients where both of their tubes were removed from 2 different ectopics and no one told them that that was going to impact their fertility later in life. Next. So uterine factor is something that comes up quite frequently, and more so in uterine fibroids. We know that up to 80% of women will have uterine fibroids at some point in their life. Some people will never know. Some people may have symptoms from it. But Black women tend to be more symptomatic at an earlier age and have a larger fibroid burden. So either more fibroids or larger. We don't exactly know why this is. Was there some evolutionary advantage to fibroids? Is it connected to a vitamin D deficiency, a chronic deficiency? In terms of fibroid exacerbation, it can be exacerbated by environmental exposures, particularly things that kind of enhance your response to hormones, and that's a lot of what's in our environment, what we ingest, what we touch, as well as family history, like genetics. And again, this is why I really encourage people to talk to their family. You would be so surprised. I give someone a diagnosis and say, okay, and then they come back and they said, yeah, so I brought it up at the table and like all of my aunts said they had the same thing. And it was like, why didn't they tell you this before, So knowing these things in advance, exposing the young people in your lives early can just make sure that it's on their radar. Just the same way you want to know if family has had breast cancer, colon cancer. Talk about Aunt Susie had an issue trying to get pregnant. This one had fibroids. These things can be important. Next. And we talked about ovarian factor just a little bit in terms of either having too much or too little, having a lower egg count, which is probably one of the more common problems that we see, especially as people get older. But there are issues where you have a high egg count with polycystic ovarian syndrome, but you're not growing, maturing, and ovulating those eggs, and that can hurt your chances of success. So, again, the longer you wait to come in to be evaluated, unfortunately, the more your chances of success in the end can be impacted. Next. So how long to try? Just want to reiterate, if you don't take anything else home, 12 months in the best case scenarios, just young, healthy people, no medical issues, no prior surgeries, no major medications. You can give it that long for sure. 35 and up, I want to see you 6 months, max. But I also just want to see you immediately if you have one of these different issues. Next slide. If you are someone who is 40 or above, just come in. We'll see you, don't worry. If you don't get a period every month, or your period only comes a few times a year, if you have always suffered with really terrible pelvic pain or terrible periods, things that impact your life, you can't go out, you have to rearrange your schedule, and you're ready to get pregnant, then I want to see you right away. You don't have to try on your own first. If you've ever had cancer before or had to take any treatment that, could impact your fertility, and similarly for your partner, if they've ever had anything like that, or if they've ever had a cancer as a child, then we definitely want to see you as soon as possible. Next. So, just to wrap it up, don't forget, infertility is a disease, okay? It is not something you did to yourself or somebody did to you. There's no juju in the world strong enough. This is to cause infertility, okay? It just is a malfunction, and we have ways to fix it. It does not discriminate and is not a dead end. Next. And that's just some ways to contact me. Again, thank you for Reverend Stacy for organizing something as impactful as this program. I'm always happy to be involved and to educate in any way that we can. So just let me know if you have any questions.
My children's fertility as they are, approaching puberty, and so that they at least have the option if they want children in the future. So what can I do to not only protect my children, but to even be an educator for young women that are within my circle?
That's a great question, and I applaud you just for asking it. I think, something that we haven't really focused on in the American healthcare system is enough prevention and being very proactive. And so I think all approaches to health with that mindset are going to be good. Something that I think is really important is being honest with children and young adults about their body, about anatomy, about what a period means. Menses are not supposed to be painful. A twinge here and there, Tylenol, ibuprofen, sure. If it's taking them down every month, staying home from school, and similarly they can think of that for their friends, and then that's not okay, and we should investigate that, and we should figure out what's going on. Things to keep your kids healthy and strong. Obviously, obesity is a big issue, and just making sure that they have every opportunity to maintain healthy weight, that if they do have chronic medical conditions, that they're managed. And then, unfortunate cases where there could be things like a childhood cancer or a significant autoimmune issue like lupus or something like that. If they're gonna be started on treatment, ask the doctor, hey, is this gonna impact her fertility in the future? Is there something I should know? Because unfortunately, it's not always offered to our children, but it's available. So we have to maybe be proactive and ask, should we have a consultation with a specialist about future fertility? And that stops everything. It's okay, let's figure that out first. We, see patients who have cancer treatments, and we get frantic emails from their doctors, hey, starting treatment in 2 weeks, can you see patient tomorrow? Absolutely. So this is a real thing that happens and is available. And then I think one thing that's going to be harder is really looking at your environment and seeing how we can eliminate our toxic exposures. You know, all of us grew up on like sugar cereal and canned foods, but now we realize that it's all like total rubbish. So, you know, when you can, using organic products, removing certain plastics from the environment, just being very scrutinizing in that standpoint, I think is important. And then the last thing is, you know, going forward, more and more young people might have fertility preservation. You know, I think that freezing eggs is going to be like the new car at 16 kind of a thing. Like, there's always going to be, your college graduation gift is going to be like egg freezing. And that is really going to revolutionize what is possible for the next generation. And the same for sperm. You can freeze sperm, it lasts for decades, and you can still create children with that frozen sperm.
Hi. In the emergency room, again, I'm an ER doctor, and the people, the first physician that a lot of, especially young black women that where I work, especially here in Brooklyn, as well as uptown in the Bronx, they come in because of ectopic pregnancy, so we are the first ones that are, you know, evaluating them. And it's true that the first thing, especially coming from male physicians, when dealing with black women, and it's with the ectopic pregnancies, is the surgical management. And I actually unfortunately, got into arguments with certain male physicians about rushing them to the OR unless they are unstable, like, as we know, it can actually, the patient can become unstable. But I've actually gotten into disagreements with some male physicians at least rushing the patient to the OR to surgically remove the ectopic pregnancy, where I would, you know, not to disrespect, because again, this is beyond my scope of practice, but would recommend that why can't we just do it a different way, where there's an injection with methotrexate. And oftentimes it caused a big argument. And a lot of the patients, especially black women, ask, I don't want to lose my fallopian tubes, can you help me? What would be your advice to me as a fellow physician to go about this, to make sure that at least that we're given a chance to preserve our fertility? And then the second question is, what is your thoughts on platelet-rich plasma rejuvenation for ovarian reserve, especially for black women?
Yeah, absolutely. So thank you so much, and I'm glad you're here because you're front line. You know, two different things. So there are criteria. When a person presents with an ectopic pregnancy, that means that they are a candidate for methotrexate or not. So some people, if they're having pain, if it's already starting to burst, you know, they're hemodynamically unstable, they need surgery, sure. If there's an in-between, you know, you can advocate for the patients by pulling up the guidelines. Hey guys, looks like her beta is less than 5,000. She's, you know, willing to come back, because that's another thing too, this perceived that they're non-compliant, right? They won't come back, they don't have a cell phone, we won't be able to reach them. They, you know, have a ruptured ectopic in the street and won't come back. So I would talk to the patient about, hey, we can do this as an option, but like, it's really important that we see you back. You could, you know, your tube could rupture, you could bleed out, you could die. And talk to them and see. You know, I had a patient who was actually just here for a short period of time and was planning to be in another state later. And I said, well, you know, we might not be able to see you. Maybe we can do the surgery. So there's, you know, there's definitely some wiggle room there. With the department, you know, there needs to be re-education there. There's actually a paper that I'll show you that, you know, looked at this. And it's an injustice issue. And package it just that way to the administration. Also, in terms of surgical management of ectopics, there's more than one way to skin a cat. So you can remove the whole tube, or you can remove the pregnancy and leave the tube, which is called a salpingostomy instead of salpingectomy. I've done the surgery myself hundreds of times. It's worked. You know, it might not be the best thing, because if you have an ectopic, that means that there's probably some damage in that tube, but it at least gives them the opportunity, particularly if it's their last tube. And so if it's a patient that's stable and it's appropriate, they should be taught how to do a salpingostomy. It's not a much longer process than doing a salpingectomy. Yes.
Take the mic, please.
So let's say like if you have like your mom like had many miscarriages in her fertility journey, but then like my mom said she had many miscarriages and then she conceived me at 36. So can that like be a genetic thing? Like could that pass down to me? Like if I'm trying to get pregnant, could that like make me have many miscarriages? I'm curious about that.
That one is not, so a lot of people have the same concern, especially about miscarriages or stillbirth or premature labor, things like that. It does not pass down from generation unless there was a reason why. Like if she had big fibroids or something like that and that was causing them, then they were removed and she was able to have a successful pregnancy, that's a different part of the story. But in general, not typically. There could be some other instances where there's like a bleeding or clotting disorder that can be, genetically linked, but I'm telling you, in general, just because your mom had miscarriages does not mean you'll have miscarriages.
Okay, thank you.
I just want to go back real quick to plasma-rich protein as a rejuvenation. So this is a process where the components of your own blood may be used to kind of help ovarian function or marketed to help ovarian function or uterine function and things like that. Unfortunately, we just don't have enough data to really say if it's helpful or even worth it or worth the money. It's being used in a lot of other areas, dermatology, orthopedics, putting it into joint spaces, injecting it into the skin and things like that. And so it's promising and I think it makes sense. We just don't have enough data to say like this will increase your chance of live birth. And again, if it doesn't help you bring home a baby, then I'm less inclined to, to suggest it.
Hi, I have a question. Through my own journey and research and Dr. Google and following the Brat story with her wife, I noticed that there's not a lot of stories or subject matter out there in regards to our community donating eggs or even sperm donors. And I noticed that there was even a backlash as to why the Brat and her wife chose a white donor. What resources are there, or are there even resources out there to encourage our own community to continue to donate? Because from my experience and reading, a lot of women who go through fertility treatment at an older age and are recommended for donor treatment, they're discouraged because of the fact there's not enough donors that look like us in the community, or for them to choose. So what resources or what can we do to help encourage or increase our community to donate?
Yeah, I think this is a huge, kind of issue that then presents as a barrier to continuing on the treatment to your family. It is true that there are not a proportional amount of donors of any African descent, and that's including egg donors, embryo donors, and sperm donors. So it can limit your options. I really want to encourage people to continue to look, because there are options, and sometimes you may have to be a little bit flexible on it. I always say you're not going for a donor that looks just like you, because very rarely a child is like your spitting image. You have to kind of consider it with your partner. Look at the people in your family. Does this donor look like they could be a family member? Is it somewhere in the realm of close to you? And I think that that's important. Again, this has been a big conversation, particularly with sperm donors of color not having enough. There was a big issue during the pandemic. All sperm donation kind of took a little bit of a dive at the same time that the demand was increasing. And then it was felt most in, I think, Black sperm donors. We have gotten some commitments from some of the big banks that they will try to change some of their recruitment strategies in ways that could promote more Black donors. You know, typically they recruit on college campuses, but Ivy League schools that don't have a lot of representation from Black students. But why aren't they at the HBCUs? These, you know, campuses are crawling with smart, intelligent, creative young Black men who might be interested as donors. So that's one thing. There are also some barriers in terms of, you know, family history. You have to know extensive family history in order to be considered a donor. You have to know back to your grandparents' level on both sides and be able to report, you know, just other kind of genetic factors or things that they can either provide or not provide. So I think in the future, maybe being a little bit more flexible on that could be helpful. Lastly, there is a proposal for a Black donor sperm bank from a woman out of Maryland. And the name of the company escapes me right now, but she's very interested and committed to this and is going to be looking into how to recruit more Black sperm donors. On the egg donor side, you know, I specifically remember when I was a college student, you know, people would take out full page ads in like our student magazine to look for egg donors. They would say blonde, blue eyes, must be 5'9" or taller, must have like almost a perfect SAT score. And so that was the idea of who was desirable as a donor. And so I think the same applies on egg donor side. We have to start recruiting in the spaces where these women are, talking and destigmatizing this to young people, because I think it can be perceived very, you know, poorly by our community. Why would you do something like that? Why would you give your, you know, self away? There's going to be somebody out there who knows you. And in this day and age, it's not completely anonymous anymore due to these self kind of testing for DNA and stuff like that. So I think talking to people and destigmatizing it, even amongst the people that you know, could really help people who are thinking about it or who would consider it to become donors. About the HPV vaccine, I support the HPV vaccine. The HPV vaccine has significantly reduced the amount of cervical cancer amongst women, and we actually have the most to benefit from that because even in the 20th and 21st century, we were disproportionately affected by cervical cancer. Cervical cancer used to be a leading cause of death for women. When we talk about Henrietta Lacks, she had cervical cancer. She died in like her early 50s. And so we used to see a lot of death from cervical cancer before we realized that cervical cancer was caused by HPV, which is a virus. So if we can prevent HPV infection, which is very hard to do in just general practice because it's so ubiquitous. It means it's everywhere. It means that 90% of people who are sexually active have been exposed. So if we can take it one step further and maybe vaccinate young people, let them build up immunity so that when they're sexually active, maybe if they encounter the virus, they're not infected, you can dramatically decrease their chance of cervical cancer. And we're actually seeing the effects of it in real time, and it's incredible.
Hello, I'm an OBGYN resident, so I actually deal with a lot of miscarriages, especially in the emergency room. And my question is, how do I relay to the patient that it's not their fault? I know it's not their fault, but I feel like I have challenges like expressing that to them. If you can give me some feedback for that.
Yeah, I think that's so kudos to you for coming out on a Saturday as a resident. Because free Saturdays for me usually were very different. But you know, I think it's not just all on you. So I think that's like the biggest thing to remember is you cannot save the world as like one person with each encounter in the emergency room. But it does go a long way to provide a humanistic encounter and to just provide reassurance. You know, there can be differences between cases and like what exactly happened or this didn't happen. But I think it's important just to remind them that this is common. So I always lead with that, is that this happens to probably 1 in 4 women, if not even more. And so it happens to a lot of people and maybe they just don't talk about it. So it's happened a lot. And that early miscarriages are not their fault. And, you know, just talk to them about some of the reasons why it could happen. It probably was an issue with the pregnancy. It said it couldn't continue. It's not going to impact your chances of success in the future. And then I think the third thing is to connect them. So especially in the emergency room. So either bring them back into your clinic so you can continue the consultation and kind of that continuity there, or send them on to somebody who you know is a caring provider who can maybe help guide them into their next pregnancy so that they're being taken care of early on. Oh, I think this is the last. Oh, we got one more.
I wanted to offer, I'm a person that's tried to detoxify my cosmetics and my life, especially when I was pregnant, and it is a maddening process. It brought me to tears several times. But the Environmental Working Group is a wonderful resource. They rate various products, many thousands of products. They'll rate as toxic, some of mine were, like on a scale of 1 to 10, or, you know, as safe as possible, like 1 or 2. And so they've really helped me, like, navigate that minefield, if anybody might be interested. And then I also wondered if there was a minimum age to egg freezing.
So the bottom limit, or like the lower age for us, would be a woman or a girl who's gone through puberty. Because until you've gotten your first period, that communication between the brain and the ovary is not established, and it won't respond to our medication. So sometimes we see like very young girls who have cancers and may need to, you know, preserve their fertility. They won't respond to the medicines for egg freezing. But as young as teenagers, they can. Now, I wouldn't necessarily encourage a teenager to do an egg freezing because it's invasive and there's a lot more that they have to understand. But like college-age young women could absolutely do egg freezing. One more question back there.
Hold up, brother. Let me give you the mic so everybody can hear you. Thank you. What are your thoughts on when going through IVF, doing CRISPR, and how effective is it or ineffective, and what is your thoughts on it? Is it something that's should be done, or is it something that you would shy away from?
So I don't know any practices that are routinely using CRISPR as a part of like their IVF treatment plan. So it probably would be more specific to your care. I would say if it's being recommended and you don't feel 100% comfortable with it, you can always seek a second opinion to figure out if that's something that is absolutely necessary for you. I can't even imagine what that would add to your cost of care. It sounds like it would be incredibly expensive. And there might be cases where it could be helpful, but it is not the standard of care at this time. So CRISPR is technology of kind of actually manipulating the DNA of sometimes eggs and not even embryos, but like very early stage embryos in terms of their genetic potential. So there are other components of the egg and early embryo that can be helpful, and some of them are mitochondria that has its own kind of impact on how cells grow and divide and things like that. And so CRISPR can allow for correction of certain genetic conditions, but at this time I don't believe that it is something that we use in the United States in reproduction.
Thank you. Good morning, good afternoon. My name is Earl Dunn. I'm Stacy's husband. And I just wanted to come up here because I see some of the men that are out here. And I want to applaud you for supporting your girlfriend, your wife, because you don't have a lot of men that support this type of situation. My wife and I have been supporting her. We went through 8 IVF, and that was an emotional roller coaster, because after each time that we did not conceive, there's nothing that you could say. There's absolutely nothing as a husband, as a boyfriend, as her man, there's nothing you could say. It is the most depressing thing that we went through. And I supported her, and I tried to support her. You know, you could bring up God, you could bring up everything, anything, and it's hard. So I just want to let the men know, support your girlfriends, support your wives, be with them. Like I say, we went through 8 years of this, Very expensive. Very, very, very expensive. Our first cycle, we went to Barbados. We went to Barbados because it was a lot cheaper. We didn't conceive. A year and a half later, we went back to Barbados, didn't conceive. And then we start in the United States. And I think we did about 4 or 5 cycles in the Chicago area. And then after the 7th cycle, my wife literally gave up. And I told her, I said, let's do it one more time. I said, I had a feeling that this is going to happen on the 8th time. And sure enough, I got that call at work, sitting at my desk. My wife told me she had conceived, and I just started crying. You know, I cried at my desk for a long time because I was excited, I was happy for her and for us. But, you know, I just wanted to share this story with you about the men. Please support them. Please support, be there, please, because this is something it's really something to the females and to the wives and to the girlfriends. This is really something. But I just wanted to come up here for about 2 minutes. I don't know if any of the men have any questions for me as a man on anything that I could answer. So I don't know if you guys have any questions just for me to, you know, answer any kind of question to go through this journey. I'm here for this, you know, during this whole session. My wife, she wanted to come up because she said you guys getting ready to go into breakout sessions. But I just wanted to come up here for about 2-3 minutes just to see if any of the guys had any questions for me, that I could, you know, support you or answer any of your questions, or even the ladies. Because like I say, this is something else. But I support my wife, I support my kid. I love my kids. As you can see, they're beautiful. They're beautiful, you know, so. My wife talked about her conceiving at 50 years old. I am older than my wife. So imagine me being my age going through this with 2 little ones, 3 little ones. I don't know where Shiloh is at, but I love it. It's keeping me young. It's keeping me great. It's keeping me healthy. I love it. So I just want to say that to the men. I applaud you, brothers. I really applaud you, brothers, for being here. And I just want to say thank you. And if you want me, any questions for me after this or doing this, I'm here available to answer any of your questions. Thank you.
Thank you, Earl. So listen, we're going to go to breakout sessions.